Okay, so we are ready to discuss external fixation. And external fixation, as you can see in the picture, uses pins that are inserted, rod screws inserted into the bone and attached to a frame, or sometimes you'll see rods and bolts that have some kind of external device that maintains the bone fragments in alignment. And you see external fixation for complicated fractures. For comminuted fractures where there are multiple bone fragments, and especially when there's extensive soft tissue damage. They can be used in compound fractures where a cast or splint might not allow the wound bed to heal. You might want an external device for something like that. They are used in leg length discrepancies, and I knew somebody who had one leg that was several inches shorter than the other, and when she was 12, she was a candidate for the Elizarov procedure, and that uses an external fixator device as well. The provider will tighten the screws on the device so that the bone gets lengthened to match the other side. It can also be used to treat bone loss from tumors or osteomyelitis. And the advantages of external fixation over other modes of treatment: you have immediate fracture stabilization, similar to internal fixation, but this gets those bone fragments back into contact with one another a lot faster than, say, a traction device would. You get minimal blood loss with the internal fixation surgeries, and we do there is a place for those as well, but they can sometimes induce a 1500 ml blood loss. So an external fixator is definitely preferable when you can use it. They allow for mobility and ambulation, and that's going to be key to this person's healing, really. If you think about this is one of the reasons that skeletal traction isn't used as much anymore, because external fixation devices allow that person to be out of the bed, moving around with assistive devices, and that's going to help your not only your bone healing, but your overall physical condition. They help maintain the alignment of closed fractures that can't be maintained in a cast. If a cast is just not a feasible option, an external fixator can help with that. The disadvantages to an external fixator are the risk of infection, and it's obvious anytime you have an entry into a sterile space from the outside, you have an increased risk of infection. You've broken the skin barrier, and now you have a pin or a rod or a screw that goes directly into the bone. So there is a risk of osteomyelitis. Body image disturbance is another risk that you take with an external fixator. This person now not only has the fracture and the loss of, little loss of independence, but now they're looking at this gigantic frame and thinking, wow, this is, this looks horrible. It's scary looking. I mean, a lot of people have an issue with that. And then you have the whole issue of whether or not this patient is going to adhere to the pin care regime. Sometimes a patient doesn't understand the risk of osteomyelitis and how difficult it is to treat and how painful it can be. And so they may be a little less likely to perform their pin care. And they could also be non-adherent with weight-bearing restrictions that the doctor places on them. So those are some advantages and disadvantages of external fixation device. Okay, so nursing care of the patient who has an external fixation device is going to include immediately post-operatively, you're going to elevate that extremity to the level of the heart, and that's going to decrease edema and promote venous return. We're going to monitor the neurovascular status, and this is consistent all through musculoskeletal. You're always going to be looking for signs of impaired tissue perfusion or impaired nerve function. So the 5 Ps again, and you should really be checking that hourly, immediately, and then every 4 hours once that patient is stable. We're going to do pin care for that patient. This is the same kind of pin care you do for a patient with skeletal traction. Again, it's the chlorhexidine solution, 2 milligrams per ml, sterile cotton tip applicators, 1 applicator per pin. And you're going to go in an outward motion from the insertion site, circular motion outward. We're going to monitor the pin sites for signs and symptoms of infection. Now, common signs and symptoms of infection are similar to what you might find in any wound or any break in skin integrity. We're looking for redness, swelling, heat, purulent drainage, foul odor. Those would be the things that you look for. Just so that you know, for the first 48 to 72 hours post insertion of the device or post surgery for external fixation, it is normal to have slight redness and swelling at the insertion site. And I'm just going to put this here so that you know to write it down. And a little bit of serous drainage is also considered normal in the first 48 to 72 hours. Purulent drainage never is, but it usually takes 48 to 72 hours to see purulent drainage. So just note that immediately post-insertion, these are things that you might see and they would be normal. Okay. We're also going to monitor for fat embolism or PE, and that can happen with any fracture regardless of the treatment modality. So, look for those signs, the tachypnea, agitation, confusion, any sign of respiratory distress, tachycardia, tachypnea, shortness of breath, chest pain. Remember that the first sign you're going to see is that confusion, agitation, restlessness in a patient who was formerly oriented and cooperative. PE has similar symptoms. You're also going to see the patient desat, and the PO2 could be as low as 60 with a fat embolism. So this is something that you want to act on right away. The difference between the fat embolism and the PE, just because repetition helps you remember that petechial rash, which is a late sign, usually see it about 48 hours from the onset of the first symptoms. Petechial rash, little pinpoint hemorrhages across the chest, the upper extremities, sometimes the abdomen. Also, you'll see them in the conjunctiva, the palate, and inside the cheek. Is fat embolism. That does not happen with a PE, so don't get confused. If a test question is asking you about a petechial rash, that's a fat embolism. If it's nonspecific respiratory symptoms, it could be either, but when you're looking at fracture of a long bone, suspect fat embolism. TEDs or SCDs, and of course we're looking at the unaffected extremity for DVT prophylaxis. DVTs do accompany fractures no matter what the treatment modality is. It's one of the more common complications, especially in elderly people, so you're always going to be alert for that. And I would just like to add one more thing to our plan. And what we're going to do for this patient is cover any sharp, protruding ends. Oh, I spelled protruding wrong. Sorry. With caps. So if your device has a lot of bolts and things that have sharp ends or hard ends, you might want to cover those with caps to prevent the patient from snagging them on things and getting stuck with them. It's just a helpful tip thing to do for that patient. Okay, so most of the time we're going to be discharging this person home, and we need to do some good patient teaching as well. And we're going to teach them to take care of their apparatus, do thorough pin care, and you're going to teach them to pay special attention to aseptic technique. Usually they'll be given a number of swabs, and they'll be given the chlorhexidine solution, and they'll be given instructions. You'll be giving them instructions before they go home on how to care for it and how often. You're going to teach them how to modify clothing. Of course, you can kind of open up seams or have a female patient wear a long skirt to cover the apparatus, just for comfort and appearance. And you're going to teach that patient, probably the most important thing you're going to teach them is to look for and report the signs and symptoms of infection to their doctor. Like I said, you're going to be sending this person home, and over the long term, there is always the possibility of infection. And that infection can be superficial just at the site of the pin, where it's easy to treat, or it can go all the way down to the bone and become osteomyelitis, where it is almost impossible to treat. So you really need to emphasize this to the patient, and really have good follow-up care. The last topic for this part of Unit 8 is internal fixation. This is another treatment modality for fractures. And internal fixation refers to the placement of plates, screws, rods, pins to hold that fracture stable. And I'm just going to make that picture a little bit bigger so you can see it and leave it up there for a minute. So sometimes you have a fracture that's really not amenable to casting. For this example, we're looking at a fracture of the head of the femur. And it would be very hard to cast an extremity in this way. So, and it may not be feasible to do a joint replacement at this point. So in this case, usually what you'll see is an open reduction internal fixation, where the surgeon will go in, manipulate those bone ends to make sure there's a good approximation for healing, and then they'll place screws, plates, rods, whatever it is they're using. In this case, it looks like they're using the intermedullary nail, and then that plate down the bottom is also stabilized with some more screws. Sometimes this is done with a closed reduction technique. From my reading, I could gather that most of the time that happens with fractures of the humerus, but more frequently you see it with open reduction for maximum approximation of the bone fragments. With all orthopedic surgeries, we worry about blood loss. As I said, the loss from an orthopedic surgery could be anywhere up to 1,500 mLs and still be considered normal. So usually if you're sending somebody to the OR for this, you want to make sure that they have a couple of units of packed red cells are ready to go. You're going to have to type and cross-match that person. So you'll be sending down a blood bank specimen for that. We worry also about DVT. People who undergo orthopedic surgery are at risk for DVTs. The incidence with some of these procedures is pretty high, especially in the elderly population. And we worry a lot about infection. Again, you really have to be very careful about not getting an infection to the bone. So orthopedic surgeons have been known to be very fussy. And those of you who have been to the OR and have seen the orthopedic procedures, you see them kind of operate in the spacesuits, and there is, a very heavy emphasis on infection reduction. Usually that patient will get antibiotics on call to the OR, something broad spectrum like vancomycin and sometimes Ancef. And then they'll get post-operatively 24 to 72 hours of antibiotics. So the nursing care of the patient with internal fixation is going to focus on reducing complications and promoting mobility. And most of your normal post-op care will play in here too. You're going to monitor neurovascular status. That's your 5 Ps again. Preoperatively, it's good to get a baseline. If that patient is elderly and they had weak thready pulses before, they're probably going to have weak thready pulses after, but it's good to know a baseline if you can get that information. And always compare one extremity to the other. But do check those 5 Ps regularly. They are still prone to compartment syndrome from swelling within that muscle capsule. Another thing that we're going to do for that patient is we're going to treat pain. It's not uncommon for patients in the first couple of post-operative days to have significant pain with this procedure. So you're going to assess pain on a regular basis, at least with vital signs and once a shift. But really, fresh post-op, you really should be assessing pain pretty frequently and offering treatment for that. DVT prevention. This is one of the higher risk populations for DVTs. So your sequential stockings, your TED stockings, getting the patient up and out of bed to a chair. They're really not going to be bearing a whole lot of weight early on, but at least getting them out of that bed, and then PT should get them moving around a little bit more as well. But we really want to prevent any kind of deep vein thrombosis for this patient. So monitor for signs and symptoms of DVT and follow your DVT prophylaxis. We're going to monitor for that fat embolism syndrome, the FES. Remember that fractures of the femur and the pelvis are the most common fractures that lead to FES. And it looks a lot like PE. Initially, that change in level of consciousness, the confusion, agitation, restlessness, and respiratory symptoms, tachypnea, shortness of breath, chest pain, desaturation of the oxygen level. And then finally, later on, you'll see that petechial rash and the fever. And the petechial rash is something that distinguishes a fat embolism from a pulmonary embolism. And you should know that. We're going to provide this patient with instruction on how to do isometric exercise. We want to preserve muscle tone and help blood return. When we get skeletal muscle contraction, it helps the blood return to the heart, and that's another way we prevent DVTs. So you're going to teach this patient gluteal setting, quad setting, calf pumping exercises. We're also going to do what we can to improve mobility. And for this, we're really going to need some assistance from our PT department. Eventually, this person will go through rehab, most likely, whether it's outpatient or inpatient. But just keep in mind that these internal fixation devices, the rods, the pins, they're not really meant to support the whole body weight. And they can break if they're stressed. You have to wait until the bone has had a chance to heal for them to be fully weight-bearing. And so usually the surgeon will prescribe some weight-bearing limits, and there will be assistive devices to help that person. Crutches, walker, usually the walker is what I've seen. But you'll see rehab. That person will be progressively expected to do more as their bones heal. We're going to monitor for signs and symptoms of infection. We're going to look for excessive pain, especially when we're a little further out of the post-op period. You're going to look for signs and symptoms of infection at the wound site. And you're going to look for elevations in temperature, white blood cell count, and if the ESR goes up, that also tells us that we're looking at a bone infection. And finally, what we're really going to do for this patient, they don't tend to stay in the hospital very long. You're looking at a 1 or 2 day stay. We're going to get them ready to go home or go to rehab and letting them know what to expect and how they can help their own healing process. So when we're getting this patient ready to go home, we need to do a significant amount of teaching. The first thing that we're going to talk to them about is how to look for signs and symptoms of complications and what's important enough to call the doctor for. Obviously, we're going to have them look for signs and symptoms of neurovascular compromise. We're going to have them look for signs and symptoms of infection. And, of course, any signs and symptoms of a deep vein thrombosis. And let them know that they need to call the doctor for those things. We're going to educate them about whatever medications we're sending them home on. And most of the time, those will be oral pain medications. And so you need to talk to them about the expected effects, the side effects, and the importance of keeping pain controlled so that they can move within their limitations and be an active participant in their recovery. This person is going to need some support at home. They're probably going to need somebody at home most of the time. Every time that person moves, they're going to need a little bit of assistance initially. And for toileting and transferring to different, from a bed to a chair, all that stuff, they're going to need somebody at home. And if they can't, if there's no caregiver to help them out, they may need a referral for home health, or they may need to be discharged to a rehab as opposed to their own home. That person is also going to need to be taught to elevate the extremity. The picture I show you is a fracture of the hip, the head of the femur. But often you can have internal fixation of fractures in the upper extremities, or in the shaft of the femur, or in the tibia fibula. And in those instances, swelling can be considerable, and you want to make sure that that swelling is decreased to prevent compartment syndrome. So teach the patient to elevate the extremity. And they can use ice for comfort for the first 48 to 72 hours. After that, there's really not much benefit to using ice. But we are going to teach that patient to elevate the extremity. We're also going to teach them the isometric exercises that we've already talked about. And if the extremity was casted after their internal fixation, and sometimes they are, to immobilize, we're going to teach them all the things that we taught the other patient with the cast care in the previous slides. So those are some things you're going to teach that patient. The patient is also going to need home physical therapy and home nursing assistance, unless they're in a rehab facility, in which case they'll get their PT there and their nursing care there. And that patient really needs to be taught to comply with the weight-bearing restrictions. Very frequently, early out, that patient's very cooperative and doesn't want to do a whole lot. And as time goes on, they get a little more complacent, but they may decide to be more fully weight-bearing than the doctor would like. And again, that can put stress on these plates and screws that really weren't meant to bear the weight by themselves. In conjunction with healthy bone, they can help support the person, but it really takes time for that bone to heal to the extent where that person can be fully weight-bearing. Okay, so this is the conclusion of Part 1 of Unit 8. It really is sort of a lot of content, and we may actually take all of the first class period and some of the second to do some more of the active class exercises. So if you bring your questions and notes to class, it sort of helps us have a little bit more of a fruitful discussion. And I think for most of these, I was able to put page numbers on where you can find more information. In fact, I think I maybe missed this one, so I'll just put it up here. This is your Hinkle and Cheever. And internal fixation only had one paragraph on one page, but the orthopedic surgery chapter was really, you're going to look at this anyway because you have to do total knee and total hip. But we're looking at pages 1118 to 1128. So take a look at them. And if you have any questions, bring them to class. We'll be discussing them there. Thank you.